Shall I broadcast or you want to broadcast? You'll
Yes,
also do that.
done redirecting. So our YouTube is live.
Okay. So start broadcast.
Yes, sir.
Okay. Wait for people to join. Give everyone a few minutes. So far we have what, 19 people and growing. So we're giving everyone a couple of minutes to join.
Sure, sir.
Okay, good evening, everyone, and a very, very warm welcome from Buddhi Clinic. We're very happy to be doing this series of webinars with the common theme, Beyond Medication. And why we are saying beyond medication is while neuropsychopharmacology is undoubtedly very, very important, and drugs play a huge role both in neurological and in mental health conditions, we do know that there is a huge growing awareness about the power of non-pharmacological treatments. And non-pharmacological treatments are all not just ancient treatments. There are some very modern non-pharmacological treatments as well. So today we are talking about something that's really topical, obsessive compulsive disorder. We've picked it because we are at a time when it's okay to hand wash as many times as you want. And yet, a few months ago, it wasn't okay to hand wash. People would wonder why you're washing your hands so frequently, or why you insisted on carrying sanitizer, or why you were insisting on wearing a face mask. So, in a sense, doing things repeatedly, not being able to stop oneself doing them, is one of the hallmarks of OCD. But obsessive compulsive disorder has a few other core features. uh, Irrational thoughts, thoughts that the person recognizes are irrational, um, those that intrude into one's conscious. In other words, I know it's my thought, but I'm not able to control it. It's repetitive, it's intrusive, I find it irrational, I wish it would go away. All those are features of an obsession. And then, of course, how we respond to that is often the compulsion. And the compulsion, when you're preoccupied with cleanliness or dirty thoughts, then it's hand washing. When you're preoccupied by thoughts of something else, then the compulsions change. And to tell you about OCD and to talk to you about a range of treatments that are available, medication and beyond medication, I have a galaxy of colleagues who have joined me. Very pleased to introduce to you the speakers in the order in which they will be speaking. Dr. Archana Vignesh is a psychiatrist. She leads the Buddhi Clinic team that serves Annanagar and Porur. And she's going to talk to us about how to diagnose OCD and what are the drug treatments that play an important role in OCD. Nitya Mohan has been affiliated with Buddhi Clinic for as long as I can remember. She bounced into VHS, soon after she finished her MPhil in Ramchandra, and we worked together forever since then. She's a clinical psychologist. She's a consultant in the Tamil Nadu healthcare system. She also helps us at Buddhi Clinic as a honorary consultant and advisor from time to time. And I'm very happy to welcome her to talk about psychological interventions for OCD. Dr. Vishwanathan leads our Porur clinic. He is a professor of neurosurgery, Ramchandra Medical College, and he is a functional neurosurgeon. And not surprisingly, therefore, he's going to talk to you about deep brain stimulation, which is really at the cutting edge of treatments for OCD. And I'm sure that that will interest a lot of us to know how you can have a stimulator inside your head that affecting your brain that's going to change your intractable OCD. Vivek Mishra is a neuroscientist. He was trained in Ramban, the University of Ramban, Haifa, Israel, in RTMS. And RTMS is transcranial magnetic stimulation, which is again at the cutting edge of OCD treatment. And he's going to enlighten us about that. And Dr. Rama Raghu is our own Chief Clinical Officer, a life holistic physician, and her specialty is connecting the dots. And she's going to talk to us about how Ayurveda, yoga, naturopathy, and a range of other ancient and holistic treatments can play a role in the care of a person with OCD. We are on a short timeline, so I will not keep interrupting the presentations. And I'm requesting each speaker to keep to time and pass on to the next. So I welcome our first speaker, Dr. Archana Vignesh. Dr. Archana, please get going. Do share your screen.
Thank you, sir.
And to those who joined us late, welcome all.
Good evening, everyone. I hope the slides are visible. I'm Dr. Archana Vignesh, and I'm going to be talking about OCD with regard to the symptoms, diagnosis, and treatment. So I'll just be...
We can't see your slides yet, doctor.
You're not able to see, sir? Okay.
Not yet. Have you shared screen?
Yes, 1 second. I'll just... Yeah. Yeah.
There you go.
Yeah. Yeah. You're able to see now, right? Yeah.
Yes, thank you.
Yeah. So I'm going to talk about the symptoms, diagnosis, and treatment of OCD. I'll be just giving a gist about everything because it in itself is a very wide topic. So as it is already been told, OCD is obsessive compulsive disorder. So it has two components to it. One is an obsession and the second is a compulsion. So what is an obsession? Obsession is an intrusive, persistent, and uncontrollable thought. It can be either a thought, it can be either an urge, or it can be an image. And it is experienced as irrational. And some of the most common obsessions are contamination, sexual and aggressive impulses, etc. So the points to be noted is it has to be intrusive, it has to be very persistent and uncontrollable. And instead of thoughts, it can be just an urge as to harm someone, or it can be just an image as to cause distress to the person. And it must be experienced as irrational. The second part, which is the compulsion, it is something which is done as a reaction to the obsession. So it is an impulse to repeat certain behaviors or mental acts to avoid distress. So it not necessarily has to be a repetitive behavior. It can even be a repetitive mental act, as in counting things mentally, or taking note of issues mentally and repeating it again mentally, wherein the people around the patient won't even be aware that they're doing something repeatedly within their mind. And this is done in order to avoid distress. That is the most important thing. Something which is done repeatedly is a mannerism, but when it is done to avoid distress, it becomes a compulsion. It is extremely difficult to resist this impulse, and it may at times involve elaborate behavioral rituals. Like they might have created an entire ritual of doing the compulsion. Like if they start cleaning, they have to clean only from the right corner, then go to the left and come back to the right. So any change in that order, then they restart. So that is a behavioral ritual. It is just not cleaning. There is a sort of a roadmap to the entire process. So it usually develops before the age of 10 or during the late adolescence or early adulthood. There's an early onset, which is more common in men, and women usually have a later onset when compared to men. And cleaning compulsions are more common in women. And OCD, it's usually a chronic disorder, but most of the times it might have a waxing and waning course, wherein the increase in severity of the symptoms might correlate with regard to the psychosocial elements and the stress or the stressors in the life of the patient. So you can have a cyclical waxing and waning course, or you can have a smooth chronic course where the symptoms are stable and reduce, or you can have a severe OCD where there is a slow decline and manageable symptoms throughout your life. So I'll just say a few points about the etiology, because it will be too biological when I go into the details. So OCD is sometimes seen in certain neurological disorders, the most common being Huntington's chorea, and any other degenerative neurological condition can present with OCD symptoms, as in even dementia and later stage can present. So the brain regions which are mostly affected are, as you can see in the picture, the frontal cortex, which is the main executive functioning part of the brain, the orbitofrontal cortex, the anterior cingulate gyrus, the basal ganglia, and the thalamus. So what, to put it very simply, what happens is this frontostriatal pathway, there is a hyperactivation, and the neurochemical which is involved is mainly serotonin. So our treatment is based on that. So we target serotonin in order to treat OCD. So to simply say, there is an overflow of obsessive thoughts, and your executive system, as in the frontal lobe, is overloaded, and this results in neuropsychological impairments. And this manifests as cognitive impairments. There is a defect in your thinking process. So so the patient or the person becomes very anxious once he's overloaded with these obsessive thoughts, and in order to reduce the anxiety, he performs the compulsive behaviors out of impulsivity, and this becomes a cycle. So this is what exactly happens. There's a vicious cycle of OCD. There is an obsessive thought. This obsessive thought is very distressful. It is, as it is perceived as irrational by the person. So there's a lot of anxiety arising secondary to the obsessional thought. And this anxiety urges the person to do a particular behavior, act, or physical or mental. And once that behavior is done, there's a temporary relief of anxiety. So actually the patient is happy doing the compulsion initially because there's a temporary relief from this obsessive thought. So this is actually a reinforcer, but the problem is it is a negative reinforcer, because this temporary relief pushes the patient to complete the cycle, and the cycle keeps recurring again and again. So every time he has an obsessive thought, he's forced to perform the compulsive behavior, but the relief which is obtained is just temporary. So then the thought resurfaces and the entire cycle continues. So the aim of therapy has to be, to break this vicious cycle of obsession and compulsion. And there are certain other cognitive, this is known as operant reinforcement. Then there are certain cognitive factors which are deficient or defective in these people. One is the lack of satiety signal. As in, like when I lock the door, I check it once. That's fine. It's normal. I leave it. Maximum, maybe I
Just
check
go
it a
on
second
YouTube and
time.
watch it.
So that's the
Corporate group
satiety signal.
WhatsApp.
Because at the end of the second time, I know that it is locked. But in these people, there's a lack of that satiety signal. So they go on checking the lock again and again. So that's what it means. And they have something known as a just right phenomena, wherein they keep repeating a particular compulsion n number of times until they just have the feeling of just right, it has been done. So there is no particular numbers or there's no particular times. They just have to do it until that urge reduces. And as I already told, any attempts to suppress these thoughts will again continue the vicious cycle. So the obsessive and compulsive symptoms in patients can be severe enough to consume more than 1 hour a day, or at times they can be so severe that they take up around more than 50% of your everyday life. So the severity depends upon the hours a day which you spend in your obsession or doing your compulsive acts. So as already told here, the person recognizes the obsession as imposed from outside because he knows that it's not his own thought or his own urge. He recognizes that unreasonable, he recognizes it as excessive because he knows it's coming more n number of times and he's not able to control it. It's totally not under his control, and it is definitely not enjoyed. So as sir was telling about COVID repeated hand washing, why that is not an obsession? Because we are able to control the number of times we wash our hands, and it is out of our own good which we do. It is not causing any distress to us. But for an OCD patient in this COVID, it's going to be even more distressing, because this hand washing ritual is going to increase in further fear because of COVID. So there's going to be a lot of distress, because of which they're continuously washing their hands. So the most common obsessions is contamination, fear of contamination with germs, insects, fear of procuring any diseases, and repeated doubts. This is a very common obsession, wherein whatever you think, there are repeated doubts questioning your decision. So you're not able to come to a particular decision. And the third is order, wherein arranging things, setting them in a particular order. That is a third common. Then aggressive or horrific images, as in hurting your loved ones. More commonly, it is either your parents, your spouse, or your children. And then it is sexual or pornographic imagery and blasphemous thoughts. These are the common obsessions which we come across. So what are the common compulsive responses? With response to contamination, it is usually the fear of contamination results in cleaning, hand washing, showering. So there's repeated cleaning, there's repeated hand washing, there's repeated showering. They bath many times a day. When they have obsessions of repeated doubts, it is the checking ritual, where they go on checking. And the next important thing is they go on requesting or demanding reassurance from others. So this is very important, because this is where the family members come into. So the person goes on, demanding reassurance from the family members, to the extent that at some point the family members are really irritated. There's a lot of expressed emotion from the family. So, and there's a lot of burden on the family members, because after some time they're not able to take it. So that is where the family counseling and addressing the family members and their expressed emotions plays a very important role. When the obsession is as in to maintain order, so the compulsions are usually checking rituals and counting rituals. Aggressive and horrific images, usually there is checking, praying rituals. And even for sexual and pornographic imagery and blasphemous thoughts, as in against God or images against God, usually it is prayers and rituals. So what happens in the latter two, the person feels very guilty. He feels he has done some sin. He feels not worthy of living, especially if the person has been a very pious person and suddenly he gets these blasphemous thoughts. He's unable to carry out his daily routine. He's unable to read his scriptures, and there's a lot of guilt. So the personality of the person is very important. So this person who's very pious and has a blasphemous thoughts is more likely to go into a comorbid depression. So it has to be addressed as a whole, OCD with depression, when compared with a not so pious person who might have blasphemous thoughts. So the personality and the routine of the person and the job which he does also plays a very important role when we treat these patients with OCD. So once the diagnosis is made, once the history is taken, and then we need the assessment. So why is the assessment done? It is a quantification tool to know the severity, how severe the symptoms are. So the most common quantification tool which we use is the Y-box, which is the Yale-Brown Obsessive Compulsive Scale. Initially, there is a checklist wherein there are umpty number of obsessions and compulsions, and you have to tick out the ones which you are experiencing. So for a person with OCD, initially, he might start with one particular obsession, like probably an obsession of contamination, and he started on treatment. But slowly that obsession may decrease, but there might be another obsession which may resurface at a later date. So if a person is having obsession of contamination, doesn't mean it has to remain the same. It can change over to something else. That can be one scenario. Or the second scenario might be the person can have multiple obsessions at a single point of time. So this checklist will help us to know what obsessions the person is having at that particular point of time. And the Y-box scale gives us an idea of the severity, as in it is a self-rated scale. So it helps us to quantify based on the number of time spent, that is the number of hours the person spends on his obsession and compulsions, and the amount of resistance which is offered to the thoughts which he gets, the distress which is produced, the effect of the obsessive and compulsions on his day-to-day life, and and the anxiety, which is and the extent to which the anxiety is impairing his work. So all these together are quantified both for the obsession and the compulsion. So that gives us an idea as to the severity. So based on the numbers, we know whether it is a mild, moderate, or a severe OCD. And that also helps us in assessing once the patient is started on treatment, whether there is an improvement in the score or not. And next will be to assess for a comorbid psychiatric illness. As I already told, depression is one common comorbid psychiatric illness in most of the OCD patients. And apart from depression, you can have other anxiety spectrum disorders like generalized anxiety or panic disorders. And in children, they can have ADHD, ADD, learning disabilities. And in elderly, there might be comorbid memory disturbances also, because of which they might have developed OCD in the first place. Assessing the psychosocial environment, this is also very important, as in the job of the person, the family, and the expressed emotions. So all this will help us in addressing the other issues which will reduce the stress of the patient. So a person with OCD on treatment, reducing the stressors will considerably help the patient. So anything which we can do to de-stress him would be of help in the long way. Next, blood investigation.
About 2 minutes, doctor.
Blood investigation is very important, as in it gives us a baseline of what exactly the patient has, his sugars, his BP, and his liver functions and all. So that once we start him on medications, we know that any fluctuation can be attributed either to the baseline or to the medications. Finally, it is the imaging. So the treatment, pharmacology, psychotherapy, neuromodulation, and neurosurgery. So the rest will be addressed by my fellow panelists. So I'll be talking only about pharmacology. As I told, serotonin is the main neurotransmitter. So the drugs of choice are selective serotonin reuptake inhibitors, SSRIs. So like fluoxetine, fluoxamine, paroxetine. They usually take 4 weeks to 2 to 4 weeks to show response, and they have to be given over a time of at least 8 to 12 weeks before deeming them to be ineffective, and we have to slowly taper them while discontinuing. So what are the advantages? It's very well tolerated, and they are very good antidepressants as well. So it takes care of both the symptoms. They are safe in overdose, which is the main advantage. Very little weight gain and once daily dosing. The disadvantages, there can be an initial activation of symptoms wherein there can be an initial worsening, which we have to usually explain to the patient so that they don't stop the medication. But that worsening usually subsides on its own within 3-4 days. Then they can have nausea, headache, insomnia, sexual side effects, but it happens only when SSRIs are used over a prolonged duration of time. And hyponatremia, which is to be kept in mind when we are treating elderly. The second class of drugs are benzodiazepines. So we usually give when the sleep of the person is disturbed due to very distressing obsessions, or when in between day he has severe obsessions that the patient becomes very anxious, so he's not able to do his work. So that time we can tell him to take a small dose of benzodiazepine. The most common one which is used is clonazepam. So advantages, again, it's very rapid, efficacious. It reduces the anticipatory anxiety, as in when the person is going to do something, he experiences anxiety that he's going to develop the OC symptoms. So benzodiazepines will help in reducing that. It's well tolerated. It is safe in overdose. Disadvantages is it might cause daytime sedation if it is given in daytime. In the night, it is an advantage. Memory problems in elderly, they can be withdrawal and symptoms and abuse potential if it's taken in excess than that prescribed, and sexual dysfunction. The last class of drugs are tricyclic antidepressants. These ones are initial drugs which were tried, like amitriptyline, clomipramine. They are very good for OCD. Advantages being single daily doses and less expensive. But the disadvantage is it has anticholinergic side effects like dry mouth, constipation, dizziness. So that was the major side effect which was limiting this. There's weight gain as well, orthostatic hypotension, sexual dysfunction, and there's a danger in overdose. So because of which SSRIs are preferred to TCAs, but you can always use a combination. So these are the three main drugs which are being used. Apart from these, when there is a resistant OCD, we can use add-on drugs like mood stabilizers like sodium valproate, or a small dose of antipsychotics like risperidone. So this pharmacotherapy, in addition with psychotherapy and neuromodulation, holistically approaching the patient along with the psychosocial and the family environment is going to be the way ahead in treating patients with OCD. Thank you.
Thank you, Dr. Archana. That was a very quick and a very nice whistle-stop tour.
Thank you, sir.
And psychotherapeutic approaches. Please put your questions into the Q&A section. We will keep addressing them as we go along. Nitya, are you there? Have you unmuted yourself?
Yes, Doc, just a moment, yeah? Thank you.
No issues.
Okay. Is the PPT on? Is it visible?
Yeah.
All right. A very good evening to all. So today, what I would be talking about would be the managing the OCD from the psychosocial and psychological interventions. So the overview of the talk, what I will be doing is a little intro, and you have a small clipping of a video, which you will get to see. Then briefly look at the assessment, and then we would be looking at the various exposure and concentration and reprocessing and mindfulness-based behavior therapy. As my colleague, Dr. Archana, did talk about OCD, I'm not really going to go too much into it. The two things which we really would want to look at is the obsessions, which is the experience of recurrent, unwanted, and intrusive thoughts, while the compulsions are primarily repetitive ritualistic behaviors. And they are being done because they want to reduce the distress which the individual is going through. If we were to look at the lifetime prevalence, one would see that it is 1 to 2% in the general population, and it is the fourth most common mental illness, and it is quite disabling. But then, with all these things in the background, there is still a delay in the help-seeking behavior. Research was done, and they have found out that it is because of the fear of embarrassment that people didn't want to take up therapy and they delayed taking help. So what we will be doing now is I'm going to play a little video just for you to see OCD. Just a moment. It is a Spanish movie. If you were to look at the lady, just notice how she's behaving. She's obsessed about the contamination, and compulsion is always cleaning up. She walks on there. Sit as well, so she needs to wipe up and sit. And again, with most of our OCD patients, we will look at cleanliness is something that we're very concerned about. So wash your hands and it's a bit of a caricature, as all know. that's a little clipping just our clients go through. It might look like, it seems a bit exaggerating, but that's what our clients go through as well. So it is quite distressing for them. So what we go about doing with the assessment, sorry, before I go on to that, I would suggest that, if anyone has Netflix, please do check out this movie, Talk Talk. It's from that movie. It's a Spanish movie, but it's a very beautiful movie, which shows various spectrums of people with OCD and how they go about with group therapy and how it helps them. So would suggest that you could see. So back to the talk with regard to the assessment, what we do is that we do an in-depth clinical interview. So where we try to build up rapport with the client, get to know the better understanding, check out their psychosocial aspects, what all has been happening in their life, and what has happened in the past and their life history. So once we get to know them much better, then it becomes very easy to decide on what kind of psychological intervention they would get benefited from. And my colleague did talk about the Ale Brown. So it is one of the tools which we really use for before we start on with the therapy, so that we know where they stand with the start of the therapy and at the end of the therapy, how their OCD has come down. So if you were to look at, there are these components of obsession and compulsions. So items 1 to 5 would be the obsessions and 6 to 10 would be the compulsions. So what we would be primarily looking at is the time which they spend on the obsessions as well as the compulsions, and how it interferes with their functioning, how distressed it is, and also how much they have a resistance towards it, and whether they have a control over it or not. So once we get a better understanding of that, that will also help us with the management wise. And what they are expected to do is to rate in the scale from 0 to 4, where 0 is no symptoms at all and 4 is an extreme symptom. So once we get to know about it, then we go on with the therapeutic intervention. So in the 70s, the very famous and the most preferred treatment was the exposure and response prevention. So the person who has been associated is Victor Mayer. So what they have found out is that ERP is very effective because it provides an opportunity for the extinction of conditioned fear responses. So what here the focus is on the behavior therapy. So if you were to look from the historic psychological way the therapy had come about, the behavior therapy before that, the psychodynamic, which didn't have much to offer for OCD, but behavior therapy did offer a lot, and they found that it was very helpful. So here, the principle which is used in the behavior therapy is that the fear is a conditioned response, which the client has learned over a period of time. So
Nitya,
what
I'm
we
sorry
got,
to
yeah,
sorry to interrupt you. Your screen is hanging.
yes.
Do you just refresh it if you don't mind? Thank you.
What do you get to see? Sorry.
We're just seeing sort of colors. We're not seeing any of the text. So just go back and do it again. I mean, just
Yeah,
flip back one slide and come back. Yeah, that's
sure.
better. Yeah, thanks. Yeah,
Yeah, are you able to see now?
yeah. Now, yes.
This
Thank
is
you.
better. Okay,
It's
Skip.
better. Thank you.
All
Yeah.
right, cool. Thank you. Yeah, right. Thank you. So in this process, what happens is that we are looking at exposing the individual to it, and we are stopping the compulsion by preventing the response. So I will give you an example of how we would go about doing this therapy. Usually it is 16 twice weekly treatment session, which lasts for about 90 to 120 minutes, again, depending on how much the individual can cope up with, and it's spaced over 8 weeks. So in here, what we will do is firstly, we will do the assessment. And after the assessment is done, we will have a chat with the client and the treatment plan where there will be a psychoeducation of how OCD is come about. So here, what with the behavior therapy is that it is a learned behavior. And we don't realize that the clients don't realize when they have learned this behavior and why they avoid doing certain things. So there is a discussion about it, about the response as well as the behavior and how the environment plays a role of making them continue with certain things. Say, for example, if there is this client who is very scared, like we saw this little clipping where she is very anxious about contamination. So what she does is she keeps on cleaning. So that is a compulsion. Her obsession is about the thinking, is about like, I'm going to be contaminated. And her compulsion is that I need to clean. So with exposure and response prevention, what we would be doing is we would expose her to things which are unpleasant. Okay. And then we would stop her from doing the cleaning. So that is where the response prevention comes in. So what we do is we identify the external and the internal stimulus which triggers the individual. So the external thing could be like, for example, it could be like while she was climbing the staircase, she kind of, bumped onto the rail. So that was something. But internally, there was a lot of anxiety. So you kind of sit along with the client and try to see what is the external and the internal stimulus. And then collaboratively, you come up with a fear hierarchy chart. So what is it that she fears so much? So initially it could be like, just walking on the staircase and bumping on the rail could be something which she's not so worried about, but that is something which is distressing her. So it could be like, 40%, or it could be like, meeting up with someone and then, giving a hug. That could be like really too distressing, which could be 80. So like that, you can collaboratively sit along with the client and draw up the fear chart hierarchy. And then what you do is that you would either confront the situation through the in vivo or imaginal exposure. So depending on how much the client can deal with, whether you can really ask them to do it, or you could expect them to kind of, do it as an imaginal way. And then they got to do it as a practice back home, and then they report back to you. So this is the initial and the first treatment therapy which came about, and people were finding it quite helpful. But then it was quite distressing for the client because it was just too anxiety provoking. So that's when the cognitive behavior therapy came in. So from the behavior therapy came the cognitive behavior therapy. So here they believe that the OCD arises because of the misappraisal of the intrusions. So here,
Sorry,
yeah.
Nitya, your screen is frozen. We are
Oh my
still on
God.
assessment. Yeah.
Okay.
You might just want to flip a few slides and get to CBT.
Okay.
Yeah, there you are. That's fine. Thank you.
I'm sorry. Is it happening now?
Yeah, go to
Okay,
CBT. Yeah.
right. Sorry
You're
about
still
that.
on exposure
So
response
here what the
prevention.
OCD says is that OCD arises. Yeah. I have moved to the CBT here while my screen see. Am I on CBT, Doc?
You're okay. No, you've gone to EMDR. Yeah. It's flipping.
Okay.
It's okay. Just continue. It's flipping. So.
Okay. Sorry about that. So technical glitch. So with OCD, so what they say is OCD arises because of the misappraisal of intrusions. So here what is happening is that we misappraise a situation, and because of that, it is the belief which is holding us back. So Salkovsky's, he emphasized on the importance of the responsibility appraisal and the belief. That is where, a lot of people deal with. So what he says is like, for example, there will be people who think that I might harm my child. So they think I am dangerous. So that is where the responsibility appraisal comes in, that I'm dangerous and I might hurt my child. And that's where the belief they hold on to. So what we do in the CBT would be to work and try to understand what is the belief system the client is holding on to, and then we work on it. So the Obsessive Compulsive Cognition Working Group, they had come up with certain belief domains. So here, the first thing as Tsiolkovsky had come up with, the excessive responsibility. So here again, the individual takes in a lot of responsibilities and believes that, I need to be clean, only then I will not hurt someone else. So that is a belief system which they might hold on to. Or over importance of thoughts. So they give so much of importance to every little thought which they're experiencing. So they try to hold on to it. And there is also the need to control of thoughts. They feel that each and every thought which I have, I need to have a control over it. If I don't have it, then I have to do something to deal with it. And also there is this overestimation of threat. So any little thing which is happening around them, they perceive it as threat, and they overestimate it, and they think that it is going to be too threatening and going to harm themselves or will harm others as well. And perfectionism. So they look at everything has to be perfect. If it is not, then it's not good enough. So I need to do everything right. If it's not, then it's bad. And intolerance for uncertainty. Again, they want to have a control over things. So once you try to understand what is the belief system they hold on to, then you start working on it. So firstly, what you do explain to the client is that it is okay to experience these thoughts. And again, once you understand what kind of belief system you're holding on to, then you try to challenge these thoughts and try to deal with them. So some of the techniques which could be used in the CBT is the didactic presentation of educational material, where, say for example, someone says, I have cancer, and they believe that they have cancer. So hypochondriacal thought which they have it. So here, one thing what you could ask them to do is like, why don't you think and read about where the cancer comes from, what is happening, and then there will be a discussion about it. And then you can challenge the belief system. Then another way could be the Socratic questioning, where you question them and ask them again why and where the belief system is coming up from. And a lot of times we do behavioral experiments as well, because cognitive behavior therapy has a behavioral component. So here, whatever has been discussed, then you ask them to put into practice in between the sessions when they report back to us. And then there is this pie technique. Say, for example, someone says, I'm responsible for everything which goes wrong. So then you draw up a pie and say, okay, now this is the pie which you have. Can you put down the percentage and tell how much of responsible you are for this particular event? So then while they're putting up a pictorial way, then they can kind of understand that, okay, only a small percentage that they could be responsible for, and the other things could be because of other contributing factors, and they will not be too hard on themselves. Then there's other thing called the cognitive continuum technique. So for example, someone has this thought, I'm immoral. So then you ask them to say, okay, why don't you rate yourself and see how much you are, immoral. And then you ask them, if someone else was supposed to do certain activities, say for example, a rapist, a person who is a killer or a serial killer, how much would you rate them? And then you try to ask them to rate themselves, and then you compare and see. So cognitive continuum technique also helps them to look at things in an objective manner. And then it also helps them to see that, they don't have to be too hard on themselves and can be quite forgiving. So with cognitive behavior therapy, primarily what you're doing is working with the cognition, as well as helping them to look at the way they're perceiving the whole situation is where they need to make a change. And then behaviorally, you do ask them to make the changes. So next comes the eye movement desensitization and reprocessing. So here what it does is it helps people with OCD to improve the regulation of emotions. So what it does is by reducing the emotional distress of the critical life events. So many things are happening in their life, which is what is, making them too overwhelmed as well. And they also have issues with regulating their emotions. So by doing EMDR, it is quite helpful. So the protocol, basically, it's an 8-phase therapeutic measure. So I'll just go with an example so it makes it a bit easier. So we had this client, for her, the thing is like she would have to keep on cleaning and she has to have a bath for almost 3 hours. So even for the session, if the session was at 4:30, she would invariably land up at 7 because she gets so anxious even before starting from home. She has to take a bath and, it keeps on going on for long. And so her issue was taking bath for long and always turning up late for the session. So that's the history and preparation. What we do in the EMDR is to explain to them how the brain is doing the processing, and you are, you are part of it, and you're trying to help it out. And you also have various ways of seating arrangements, and you explain to them, and then you also tell them how you can do the stop sign, and based on that, you explain to them. So then you go on to the assessment. In here, what we do is the target selection. So here for her, the target selection was that I need to be able to take a bath quickly and get out of home. And then her NC, that is negative
Nitya,
cognition.
a couple of minutes.
Yes, I will
Thanks.
finish that one. Thank you. So her negative cognition was like, I am not clean, and the positive cognition is I am okay the way I am. And the validity of cognition is how true does she believe that statement is. And the emotion was sadness and anger, which she had. And how distressing is sad is a subjective unit of distress. So she found it very distressing, 9. And location in her body, she felt it all over her body that she was not clean. And desensitization is a process where we are doing a bilateral stimulation, where we ask the client to hold on to all these thoughts, the images, and the sensation in the body, and do a bilateral stimulation. wherein the change happens. So once the change happens, she's able to move from maladaptive thought process to an adaptive thought process. And then in the installation phase, what happens is that we look at the process of cognition. So she would like to believe that I'm okay the way I am. And we check on if it holds the same or there is any changes at all. And in body scan, we try to see if there is any remaining issues which need to be sorted out. And then we bring about closure. And then we reevaluate to see how the whole thing went about. So with this client, we did for about 6 sessions. And after that, she was so relieved and she could, turn up for sessions on time, which was a great thing for us. And she was able to, take bath quicker. So she was able to do it in about 30 minutes after doing this technique. So the other thing is the third wave therapy, which is the mindfulness-based behavior therapy. So now it's a lot more people are moving into mindfulness-based therapy. So here, what it does is it integrates the intensive exposure and response prevention, and along with that, there are other things which are added on. So one is the modified 4-step method, where we relabel. So what we do is, like, for example, someone is having excessive thoughts. So then you say, it is my obsessions which I'm experiencing. So what you're doing is you are labeling what the individual is going through, and not, sometimes people feel that, oh gosh, am I going bonkers? And they get pretty worried about it. But if you're going to label, then you understand what is happening with you. And then you reattribute it. So when someone is experiencing same thing, and then you say, it is my OCD and it is not me. So what you're doing is you're again reattributing your experiences and say, it is my OCD which is making me behave this particular way. And you also refocus. So if there are some compulsions which you are pushed and you want to do it, but then you refocus yourself and say, I'm not going to do it, but I will do something which is more productive, and you revalue it. So by doing this is a self-help technique which a lot of people can do by themselves. And if they're still too distressed, we are there to help out. So this is by the brain lock system. They had come up with this 4-step method. Then there is this extensive writing exercise where you expect the client to write on what are the things that they're going through. So this again is like an exposure. And then with behavioral activation, what you expect them is to do the activities of whatever has been discussed. And then pharmacotherapy, weight, and time management, if required, is being done. So primarily with the mindfulness-based behavior therapy, you spend about 2 planning sessions, 15 daily ERP sessions, which is minimum 90 minutes, which is quite extensive. And it's spread over 3 weeks, and there are daily homeworks and psychoeducation and relapse prevention is being done. So thank you very much. That's from the psychological interventions.
Thank you, Nitya, for a quick whistle-stop tour, and apologies all for the technical glitches. It's to do with bandwidth and with use of some slide variants. A great pleasure in inviting Dr. Vishwanathan to make his presentation on deep brain stimulation. Dr. Vishwanathan will talk to us about the neurosurgical approach to intractable OCD.
All right. Has my screen been shared?
Yes, it is. Yes, thank you.
So thank you, sir. Thank you for the kind introductory words that you had said. And my talk, I'd sort of want to title as the promise of deep brain stimulation for various reasons that as I go along in this presentation, it would be evident. People who have not heard of this technique may think that this still from a movie is something, sort of torture that happens, operating the brain, sticking an electrode into the brain and things like that. But let us demystify it and put people at rest. Let us start from the basics. What is deep brain stimulation? Deep brain stimulation is a technique whereby an electrode is implanted into the brain, and you have a pacemaker that sends in electrical currents through the wires into a deep part of the brain. The deep part of the brain could vary depending on the disease and the condition. Now, this is similar to a pacemaker for the heart, and it is easier to understand that if you look at a video, short video, about a patient with a a psychological disorder. So this gentleman has tremors, and you can see how it affects him and how surgery can sometimes be dramatically, beneficial.
Dr. Vishwanathan, we can't hear anything. Is that meant to be that way?
Not really.
Okay.
Okay. So essentially, you can see here that this gentleman has so much difficulty in even writing his, signature and things like that. And that's the earlier version of me who's explaining about the operation. So essentially what it is this is a technically demanding operation, and takes quite a bit of time, almost a full day. You can see a short video of this gentleman now going to the OR. He is awake during the first 3/4 of the procedure. There he is. The procedure is happening on the head end. And there a hole is being drilled into his head. And now electrodes would be passed through that, so that we can see how his tremor changes as current is delivered through that. So here you can see the dramatic response on table. The person who couldn't have a second without the hand shaking is pretty much perfect. So the reason I show this video is because for such physical ailments, the feedback and the response that we as clinicians and surgeons can see during the surgery is instantaneous. Whereas for conditions like OCD, the response and the feedback loop is a little bit more slower. And but however, we can have during the surgery, everything else remaining the same, and the patient would be similarly awake, and they would we would be speaking. The clinical psychologist and the psychiatrist would be in the OR doing a host of tests to see whether there's any beneficial or negative effects that they can see. Now, going to about the history of DBS, it isn't as modern as one would think. Even 5 or 6 decades ago, people were experimenting with putting in electrodes in the brain. And one of this earliest indications were in psychiatric patients. So mostly it was psychosurgery patients where they tried doing a two-way communication. And in fact, in the USSR, it was Natalia Bektereva who was one of the earliest pioneers of deep brain stimulation. But this was the old era of DBS. And in the old era, the psychiatric indications took precedence over the movement disorder. However, in 1987, in France, Alim Louis Benabid and Pierre Pollack introduced deep brain stimulation for Parkinson's disease. Now, it was only after this that this field really exploded because the electronics were miniaturized, the battery technology had matured, and therefore DBS was much more promising than the earlier era where the batteries were bigger, the wires were not that great, and things like that. And they have demonstrated extreme success in Parkinson's disease and other movement disorders. And after which the interest has come back into thinking whether in select patients with psychiatric conditions like OCD, whether DBS could be beneficial. Here's another short video that you can see of another patient with a disabling movement disorder. And here, this is him 1 week after surgery. So one who can't even move before the operation can walk unaided. So in 1976, people defined what is functional neurosurgery. That's my subspecialty. It is the selective surgical removal or destruction of nerve pathways for the purposes of influencing behavior. So that was the first definition of functional neurosurgery. And we've come a long way from there. Right now, functional neurosurgery is predominantly for movement. And right now, the interest is coming back for psychiatric conditions. In the previous era, psychosurgery was popularized by Walter Freeman, along with the neurosurgeon James Watt. Unfortunately, some of the indications that they chose and the way the psychiatrists thought of performing those procedures led the procedure towards a lot of disrepute. The word psychosurgery itself is considered a bad name. And we shall find out why that is. In fact, the stereotactic frame that is a basic requirement for functional neurosurgery was first used for psychosurgery. And various procedures were done, thalamotomies, pallidotomies. And it is the Pappas circuit that the first year medical student learns that at any point in the circuit, people have either placed a lesion stereotactically or put in electrodes and done deep brain stimulation for improvement in various psychiatric conditions. So here another diagram. Now, there are various common procedures that can be done and were done before. One is a cingulotomy, where a lesion is placed in the cingulate gyrus, a capsulotomy, where the anterior limb of the internal capsule can be lesioned, and subcaudate tractotomy. These were the common procedures done in the past. And as you can see, this is the sort of early air ventriculograms and early primitive CT scans that were used. We have come a long way from there. And with all of these procedures done with imaging that was not very developed, the results were actually pretty good with all of this. Despite more than 50 years of documented experience about the efficacy of stereotactic surgery, these procedures are very rarely used. And why they are rarely used is because of the fear about doing what is psychosurgery when because of the historical reasons. Now, the Walter Freeman, who I had mentioned, his shadow looms over a new generation of physicians who practice today's psychiatric surgery with better technology, better understanding of the brain, and better ethical guidelines, but still the field is not really developing in that direction. So this would interest the physicians in the audience that a procedure like anterior capsulotomy mean change is significantly better for the patients who underwent the procedure for the various conditions, and similar for the cingulotomy, the limbic leucotomy, and the subcaudate tractotomy. Now, coming to deep brain stimulation. Who are the patients we consider deep brain stimulation for OCD? Dr. Archana had mentioned about the Y-box. It is for the patients whose Y-box score is pretty high, and the illness has lasted for more than 5 years. The patient should be able to understand the procedure and should be able to give a written informed consent. And there are various exclusion criteria as well. And the main important thing is to establish that the patient is resistant to a variety of medical treatments, which have all been given for sufficient period of time and sufficient doses. And this patient should have had other therapies that Nitya had mentioned and should have failed all of them as well. And this complex looking graph and slide shows that overall there is a improvement in the Y-box score after deep brain stimulation. So let us look at how scientific this is. Something like ECT has a level 1 evidence for long-term efficacy and a level 2 evidence for safety. And RTMS, which Vivek Mishra would mention, also has level 1 evidence for acute efficacy and level 1 evidence for safety. Whereas at the moment, DBS is only of a level 3 evidence because research is still underway. There are major, I would anticipate would change in the near future. And even for depression, deep brain stimulation can be done. Now, this is my penultimate slide, though this is the conclusion slide. I have tried to explain that surgery in the modern era is safe and should be considered for patients in whom everything available has been tried and still they are fairly wrecked. Modern stereotactic surgery is very safe and accurate. The chance of risk to life, risk of major complications like bleeding in the brain, coma, and things like that are less than 0.5%. In the Indian context, in patients in whom deep brain stimulation is a very costly procedure, in those in whom cost is a consideration, lesioning is still available, still safe, and can still help. And finally, DBS is suitable in carefully selected patients. Now, why I had mentioned the title as the promise of DBS is because there is a very significant piece of legislation that has come in 2017, the Mental Healthcare Act. Now, that act places restrictions on psychosurgery. It basically says that the psychosurgery will be done only for patients in whom they are able to consent, which is fair enough. And then the approval from the local board, the mental health board, for performing the surgery. This, unfortunately, has meant that in the last few years, no psychiatric surgery has happened, though before this, many patients have benefited. Though this piece of legislation is extremely useful for safeguarding patient interests, I think when the functioning of these boards become more streamlined, many more patients would be able to benefit from this extremely safe, effective procedure. If you really look at it, when you place something like an ECT, electroconvulsive therapy, which is an external shock onto the entire brain, this is a focused electrical stimulation into a slender circuitry in the brain, which has a promise of making many patients who are suffering suffer far less. Thank you.
Thank you, Dr. Vishwanathan, for that very interesting and very hopeful talk about the promise of deep brain stimulation. Clearly something that we need to keep in mind for the future and even in the present when we have intractable patients. Very happy to invite Vivek Mishra to talk about RTMS, which is an important treatment, and one that, done properly, holds great promise.
Yeah, sorry. I think now I am audible.
Yeah, you had not unmuted yourself. Yes, thank you.
So, what I'm going to discuss is the integrating the neuromodulation in a multidisciplinary care paradigm for obsessive compulsive disorders. So, as we just discussed about what is transcranial magnetic stimulation. So, it is a non-invasive, non-convulsive neuromodulation technique initially developed in mid-1980s as a tool to study human neurophysiology, as we can stimulate the brain without actually opening up or making a hole in it. So TMS is completely non-invasive, unlike the DBS surgery where the hole is being put up, like as you have seen in the previous discussion by Dr. Vishwanathan, and it does not require any anesthesia or sedation. So since that time, there are several diagnostics and therapeutic clinical applications for TMS has been developed that are part of a standard of care in neurology, neurosurgery, and psychiatric clinics around the world. So when we are talking about OCD and we talk about the neurobiology of OCD and how the TMS can able to help it. So if we see the green area and the hypothesis behind using the TMS is it is being said that the caudate nucleus, which is a deep-seated nucleus in the brain, thought to be damaged, and it cannot suppress signals coming from the orbitofrontal cortex, which is another part of the brain. Now, when this happens, the another area called thalamus, which act as a transformer of passing the signal from our frontal lobe to processing areas, could not able to suppress and send strong signal back to OFC, and which responds to an increasing of the compulsive behaviors and anxiety disorders. And when we think like where exactly these substrate or the nucleus are, they are just below this green supplementary motor cortex area and the premotor cortex. So it is right there, and that's help us because they are closer to surface. We can stimulate them using the TMS. And how TMS works based on the Faraday's principle, rapidly fluxing the magnetic field when it is being subjected. So the coil is being placed over the head. It induces the current in the underlying cortex, totally being non-invasive, permits focal manipulation of the cortical activity. So when we are working with any the areas like supplementary motor area, we are talking about orbitofrontal cortex. We are looking at a precision of 1 to 1.5 centimeter at max. I will just show you this video that how the TMS looks like. So this is a higher frequency TMS protocol. So this girl is undergoing the TMS sessions, and you can see she will be perfectly fine, and she will be talking, and while the TMS is happening. And then every time there is this pulsing sound, the tapping, that are the magnetic pulses. This is the high frequency 10 hertz pulses, which is being delivered to her prefrontal, dorsolateral prefrontal cortex. And there is no sign of pain. And usually this is the case with most of the patients who does not feel any pain or discomfort during the session. And that makes TMS one of the crucial non-invasive neuromodulation techniques. Now, if we talk about a little bit big analysis or meta-analysis which have been done recently, and it finds that the low frequency RTMS and protocol targetings the orbitofrontal cortex or supplementary motor area seem to be most promising. There are several zones, like if we think of 5 years back, there are only these numbers of study which are present, which have looked the use of active TMS versus sham TMS, and you will see that the red mark is clearly below, like crossing the 1 mark over here. So it favors the active TMS, so the patients are getting benefited and not just the sham. But now if we think we are having so many studies with different regions. So we are looking for right dorsolateral prefrontal cortex, we are looking for left dorsolateral prefrontal cortex. Some people papers study the orbital frontal cortex. We are looking for supplementary motor area, and most of the studies have shown the good efficacy of the RTMS over the sham, which is the control TMS in the setting. So now we are thinking that if we are reducing, so we are looking for a low frequency TMS stimulation over the supplementary motor cortex, and how does it work? So it involved at the functional level reduction in corticostriatal hyperconnectivity accompanies successful treatment of OCD with dorsomedial prefrontal TMS. So what it just means is not only it is being shown in the Y box score, which the patients are telling and like they are reporting at the intervals, you can also see on the functional magnetic resonance imaging. So there are changes which are happening in the brain, which leads to the reduction in symptoms. So this is the neuromodulation unit at our Buddhi clinic. So in 2018, we have established the neuromodulation lab with 4 Tesla Neurosoft MSD stimulator with 2 coil variants, which is one is a figure of 8, a standard coil, and the angulated figure of 8, which can stimulate little broader regions. Along with it, we do have the brain mapping studies, so which can be done before and after. And surprisingly, the pre-brain mapping study definitely correlates with the post-TMS treatment, where there is a reduction is being seen in certain specific regions. So it is not only the symptoms, we are targeting the thing on the biological basis. So since then, if we can see, we have in our all of the groups, we have mostly we are having a patient cohort of depression, Parkinson's, and here is the OCD, which we have done for the 10% of the things. So we are looking for the 7 patients so far who have completed the course, as well as completed their 1-month follow-up. So if we can see in this slide particularly that there are several different neurological and psychiatric disorders we can look for using the TMS. And how we do it at Buddhi Clinic is that we have integrated the holistic integrative medical therapy, which consists of physiotherapy, psychological therapy, occupational speech therapy, and complementary alternate medicine like naturopathy, Ayurveda, yoga, along with brain stimulation. Now, as we have seen, like Ms. Nitya was talking about the the EMDR and various psychological therapies. Now, again, there are several studies which have been shown that a person taking pharmacotherapy, psychotherapy, and TMS is having more quick and long-lasting impact on the brain and the symptoms, rather than a person is having one of the modality alone. So this gives us an advantage that if we are combining psychological therapy, we are doing pharmacotherapy and the TMS, it's definitely like, you know, as per our experience, we are looking at a very promising results. So what I will show, and this is what the Y-box score looks like. So we do 3 to 4 times a week, and we repeatedly do the Y-box scoring on them, on the patients undergoing it. And we look for when at week 0, the average score was 32 with the standard deviation. At week 2, we are looking for a significantly reduction of the scores, and it goes till when we end the TMS treatment, it is 15. Now, when we look for that from 32 to 15, although it is a 50% reduction, and which shows that it is the patients are responder to the RTMS. But the thing which we say is from the severe symptoms, the symptom reduced to the mild to moderate symptoms over the 7-week treatment. And at follow up, they are able to retain the scores on the same. So like they are not as severely as affected as they were. But interestingly, when we do the PECS and anxiety inventory, and we see the similar results over here, and which the shows from the 24 again looking for moderate to severe, and then even at the follow-up they show the minimal to very mild level of anxiety, which means it also can be interpreted as it's the patient is not only feeling in like reporting the reduction in the symptoms, but we are validating that they no longer feel anxious when we are doing even at the 1 month follow-up. So this is what it's our experience at Buddhi Clinic. When we are talking about RTMS, I just wanted to touch briefly about one more neuromodulation technique. So it's called transcranial direct current stimulation, TDCS, and it has been also been effective. So this paper is being published in 2015, and what it says, along with the treatment of SSRIs, if we are using the TDCS, as if we recall the first slide, the areas are quite superficial, and the SMA area, if we can able to stimulate with the transcranial direct current stimulation, they are found to be more effective. So just to conclude, integrating RTMS in multidisciplinary care paradigm is paving our way to look forward in developing a holistic treatment approach for a range of neurological and psychiatric conditions across lifespan. Integrative therapy not only focused upon the behavioral and psychological symptoms of cognition, but also aim to improve the quality of life and activities of daily living. Because that's the thing what our patients are looking for. If they say, okay, I don't have the thoughts, the disturbing thoughts as of now, but can I able to go back to my work? Can I start doing the activities what I was doing before? And just to share one of the experience what we had with a female of 32 years and having the severe case of OCD since last 10 years. She was on medication, and she was very afraid, and she was that to start a a family together with her husband, and because she was having the thoughts repeatedly, and when at the end of the 7 weeks program, her thoughts were totally diminished. She was and she maintained the treatment gain for over 1.5 years, and she is still in with the follow-up with us. And I think that is what we are looking for. So not only in the 7 weeks the patients are getting better, but they should be able to sustain the treatment gain in a long-term way. So with this, I would like to thank everyone. And if anyone of you have any questions about the RTMS, you can definitely email it to me at vivek@buddhiclinic.com. Thank you.
Thank you, Vivek, for that very lucid presentation of RTMS and how, as part of an integrated care paradigm, it is making a difference for patients. Finally, and perhaps very, very importantly, we have Dr. Rama talking to us about the integrated and holistic care and how ancient wisdom, when combined with modern medicine, may play a role. Dr. Rama Raghu.
Thank you. Is it visible?
Yes, ma'am. You can go ahead.
So good evening. At the rear of the program, I'm happy that I'm here to connect the dots, like Doctor put it at the beginning. The integrative therapy is a novel concept that we brought in about 10 years ago. So it's really a long period. When we started with what we thought was a wonderful idea, and it has proved to be. We evolved as we came to know and learned along the journey. So initially, why did we come up with this? It's because and they often very progressive. And we have also experienced many a time that medical and surgical interventions, no doubt they've been getting better, but sometimes there seems to be a limitation, and people are exploring beyond medication. Is there anything else that can be done for a particular disorder? And how did we bring this together, the concept of the integrative therapy? by bringing together the best of the cutting edge new treatments along with the best of the ancient medical traditions, that is the Ayurveda and the naturopathy, by seamlessly integrating everything together so that they complement each other, and also knowing what works and what doesn't work. And then by constantly working on the protocols and the procedures so that we have a maximal impact in terms of outcomes, and so that they are also measurable and sustainable and replicable. So you can see that there is a basket of therapies for the many symptoms that we focus on, primarily the pain and disability, cognitive decline, mental health, and lifestyle conditions. So you can see that it is very holistic, even in terms of the symptom focus, and a large number of therapies in the various domains. So you've already heard about neuromodulation, where we have the RTMS and the TDCS treatments. And then we also have the physical interventions, which we call the mobility lab interventions. We are all familiar with the physiotherapies, exercise, electrotherapy, and the others. And then we have, of course, the mind lab, the psychological interventions, which are of primary importance in a disorder such as an OCD. So you have a basket of interventions there, the behavioral therapies, and then the relaxation exercises, the cognitive retraining, etc. And then you have the complementary and the therapies and alternative treatments. So there you have the Ayurveda. They are all external treatments that we do. So Ayurveda, you have a number of massages and foments with medicated oils and poultices and herbal preparations. And naturopathy, we have pressure techniques, acupressure, acupuncture, reflexology, and along with it, we have hydrotherapies, mud and herbal preparations. And very important in the naturopathy treatments, you have the yoga therapy that we are all familiar with, but still needs guidance when it is being done. And the speech and swallowing therapy, wherever it's relevant in the condition that we'll be treating. So to deliver all these treatments, we'll have a quick look at the team. So we have the allopathic doctor lead. That is, we have a team of neuropsychiatrists and the neurosurgeons, the family physician, the neurologist, who are the clinical lead in all our centers, the 5 centers of Buddhi and in Chennai. And we are supported by very well qualified and trained team. Like I spoke about, in the mind lab, we have the clinical psychologists who do the evaluation and deliver the therapies. And in the mobility lab, which is the physiotherapy lab, so they do all the physical and the occupational therapies. Brain lab, neuromodulation by a neuroscientist. And the rehab lab, you have the speech and swallowing pathologist who does the evaluation and does therapies. The CAM lab is led by the Ayurveda and the naturopathy and yoga physicians and supported by therapy assistants who deliver the treatments. And the evaluation from the nerve lab, we do the electrophysiology tests. It's a gamut of tests, so which includes the EEG, the brain mapping, and then the nerve conduction studies, the sleep study, etc. So you can see that we are well equipped to look at all the domains, to evaluate it well, and we come up with a treatment program. So I think the bedrock of this comprehensive process is a multidisciplinary assessment. So, so it's the clinical assessments. You have the med lab, that is the doctors doing the history and a detailed general examination and a neurological examination. We've already heard about the Y box, the clinical interview, and the anxiety scales that are done by the psychologist. The TMS assessment in the neuromodulation department. The CAM lab physicians, they also do the pulse and the constitution diagnosis, because that is how that is how medicine works for them, and also the nutritional assessment, speech assessment, and mobility assessment when required. So if they have pain and other physical disabling issues, we also do that. Nerve lab, we have the EEG, and of course we do the lab investigations, all the routine blood works and anything else which needs to be done. So if you look at having looked at the assessment, I think you will know that we're able to quantify, like the Y box is there, and then you have the BAI, etc. So we're able to quantify the problems that we have, whether it's pain and whatever else is there. So it's not just qualitative. So we have two parameters where we are able to assess as to how bad a problem is, and therefore what all needs to be done in terms of therapy. So after we look at the all the assessments, so we have looked at all the domains, the physical, the cognitive, and the psychological domains, and we put together an integrated therapy program, which is focusing on maximizing functions and abilities for the patient, and helping the family or the caregiver as well. So we've already heard about the medicines, the SSRIs and the benzos, the tricyclic antidepressants. We also put in supplements if we find any deficiencies in the blood work. So we put in those. And primarily, it's a mind lab lead. That's you have the psychological intervention. So we've heard about the CBT, we've heard about the ERP, the EMDR. We also handhold the family and take care of them and help them to take care of the patient better and of themselves too. The neuromodulation, it could be the TMS or the TDCS. There'll be usually 20 sessions, which spans over 5 to 7 weeks, and about 20 to 30 hours of CAM lab treatments that I spoke about. Yoga and acupuncture, acupressure, reflexology, and certain treatments in the Ayurveda domain as well, which I will be talking about. So you're looking at a large number of hours, and we start with the intensive program. So the patient needs to come in every day for a couple of hours, definitely, spanning over 3 to 4 weeks. And then we go on to a step down program, which is 2 or 3 times a week for the next couple of months. So that is the way the program is chalked out. So we have two CAM experts. Dr. Agastya is an Ayurveda physician, and Dr. Divya is a naturopath physician. So these are the treatments, the external treatments that are done, the Panchakarma therapies. So you have the Nasyam, which primarily entails the massaging of the face and the forehead, and steaming and inserting the Shirabala Thailam in each nostril, thus opening up the nasal passages, which helps brain function. And the Shiro Abhyangam is a massage of the head with medicated oil, which is the Brahmi Thailam or the Shirabala Thailam. And this helps in relaxing the person and in reducing anxiety, also improves sleep. The same also happens in Shiro Dhara, where you have the medicated oil, which is the third picture. You have warm medicated oil dripping on the forehead of the patient over around 30 minutes, after which it is wiped off. And as in Shiro Abhyangam, it provides a lot of relief in terms of relaxation and reducing anxiety and improving sleep. Coming to the diet and lifestyle, this is applicable across the board to all of us. That sleep is extremely essential because it plays a role in relaxing the mind and keeping stress and anxiety down. Exercising daily for 30 to 45 minutes, 5 to 6 days a week. Anything more than that may not be of much use. Practice of yoga and meditation and breathing techniques such as pranayama. A diet which has enough of the proteins and vegetables and fats, fruits, vegetables, whole grains. And very often we see that they have problems with the gut. So you exclude irritants. That I think we need to have a food diary and exclude what doesn't agree with us, and then follow the rest of it, and not go just by the blanket rules. Avoid excessive intake of any caffeinated products, especially in the evening, and practice the deep breathing and relaxation techniques. Have warm baths to relax the mind and the body, and avoid smoking, alcohol intake, and drug use. So more about diet, like I said, the gut health seems to have a very great impact on our mental and physical health. So probiotic foods, I'll start from the bottom. Probiotic foods, you have yogurt, and you have many fermented foods that keep the gut biome optimal. So that seems to be playing a very important role in keeping us well, and also the way we respond to situations. Using having nuts, almonds, and walnuts, so you can either blanch them and have them in the morning, or you can indulge a little more, maybe fry it with some pure ghee, and then if you're not diabetic, add some sugar and then have it. Very delicious way to start the morning. So they have brain nourishing properties. Walnuts have a lot of EFAs, and they help correct neurotransmitter imbalance in the brain. They also have important minerals, magnesium and calcium, that help in relaxation. Poppy seeds, you can make a fine paste. They obviously have a relaxation property, and also promote sound sleep. Ashwagandha balances brain chemistry. It is an adaptogen, so it also keeps the cortisol down, which plays an important role in anxiety, as we all know. It also stimulates the brain-derived neurotropic factor, and keeps enough of it so that the brain health is good. Curcumin is good old turmeric, along with saffron. Both reduce inflammation. We use it in our cooking very regularly, as we know, and it has antidepressant properties and keeps dopamine and serotonin optimal, which play a role in OCD. So there are very many things that we heard of in terms of lifestyle and diet and interventions, etc. But there are many things that we could correct if we do an introspection and look at our diet, look at our lifestyle, little things like sleep, what we eat, the way we exercise, and whether we have a schedule through the day, things like that. I think those go a long way in improving our lifestyle and our physical and emotional health as a whole. Naturopathy therapies, we have acupuncture and reflexology. Both are pressure techniques. And these are the points that the naturopathy doctor, after assessment, they apply the pressure techniques. Reflexology is based on the principle that you have the various parts of the body represented in the hands, in the feet, and the ears. So pressure techniques here help heal the different problems that we have. And the yoga is of immense importance. All of us know that it plays an important role, and when practiced well, we are able to feel the impacts. So you have asanas and you have breathing techniques that are customized after the assessment. It's one-on-one and taught and guided and supervised by the naturopathy doctor when you're doing it, and then you can practice it at home. So winding up, I think I've connected the dots. I'd still like to talk about the highlights of the integrative therapies. You've seen that multidisciplinary assessment. So when you assess and evaluate a person comprehensively, you have a diagnosis, you're able to quantify the problems, and you know whether your therapies are working. So you have a pre-therapy score, you have a post-therapy score, so you can see what's happening. Mid-therapy, like Vivek said, you can check the scores again and you can see whether you're moving in the right direction. And you can also change the therapies if you want to. So I think there's a good assessment gives scope for maximal impact in terms of outcomes. There's a seamless blend. You can, like I did speak about a basket of therapies, a seamless blend is possible. Things that don't agree with you, we look at all of that. Things that you've done and not work, we also look at that, and we see how we can put whatever there is for maximal benefit, so that the person feels better. It's all available under one umbrella, and we're focusing on enhancing relief and also keeping the impact continuous. Though there are, like I said, it's disabling. There are progressive illnesses. There are relapses, which also happens in OCD. So the hand holding and getting on with the step down programs after the intensive programs, I think that is of utmost importance, and keeping in touch with the treating team and doing what is required. And we are able to improve coping mechanisms for pain and for disability and for mental health, all our areas of focus. And definitely the emphasis is on holistic wellness, looking at all the domains. So you need not really run around for the various other problems that you have, because everything can be addressed. in this kind of approach. And overall, we are able to ensure that there's an improved quality of life. Thank you.
Thank you, Dr. Rama, for, I think, really connecting the dots extremely well. And may I say that integration is not just putting things under one roof, making treatments available under one roof. It's also about selecting the right treatments for the right patient. And it's about bringing them together in a way that is scientific and humanistic at the same time. So that teamwork is what integration is really is, and seamless teamwork is what we try to do at Buddhi Clinic across all our branches. Thank all the presenters for an excellent, sharp and brief presentations. A few hands have gone up, so I'm going to request Vivek to take control, and people can ask their questions live, and we'll try and answer them. And then, of course, we can take the Q&A as well. So please put up your hand if you want to ask a question.
So we can see a question from D. Alamelu. So they have, okay, I think they have put down the hands. Okay. So you have to just raise the hand, and I will allow you to, I will unmute you, and then you can ask your questions live.
So there have been a few questions about, while that is happening, let me just ask, there have been a few questions about which are of interest. One question that was asked, which is quite interesting, from Purnima, is for Vivek. She's asking about, are there specific OCD symptoms that respond to RTMS better than others?
Okay. So when, what our experience with the TMS is, although we are targeting the areas which are common to both the obsessions and the compulsions, but if we look for the other studies, the people who are having a compulsion symptoms tends to be more, prove to be more responders. However, if we are looking for obsessions, and RTMS combined with the psychotherapy seems to be more effective. So if we are looking to enhance the effect of the TMS, I suggest the psychotherapy will be an important add-on apart from the pharmacotherapy.
Thank you. Dr. Vishwanathan, there's a question from Dr. Nandakumar about the cost of DBS. Everyone gets worries about the cost of DBS.
Yes, sir.
And you perhaps can tell us about lesionectomy as well.
Yes, yeah. So essentially, DBS, there are various, it's like what implant you choose. There are various companies available, various brands available. But broadly, they are divided into either a rechargeable or a non-rechargeable battery. The rechargeable is like a mobile phone battery. It lasts longer, it's thinner, it's more user-friendly, and we can deliver a lot more current because it can be recharged and it lasts longer. Typically for OCD patients, they would require higher current. So therefore, we recommend a rechargeable. A non-rechargeable is like a ever-ready torch battery. So there it lasts less, but there's no action that the patient needs to remember to charge it. And charging is not plugging your battery into a socket. There's an external through the skin charger that comes that they need to do once a week or so. Now, the total cost of the procedure would come to somewhere around 8 or 9 lakhs for the lower cost implant and about 13 or 14 lakhs. If we do for the stereotactic lesioning, radiofrequency lesioning, the cost of surgery would be like any other brain operation, maybe 1.5 to 2 lakhs. It can even be covered under the Chief Minister's scheme if we were to do it in, say, Sri Ramachandra Medical College Hospital. The other thing is the responses for these patients, since we have done a few for OCD, when the electrode is implanted and the current is not turned off, the patient gets good relief for about 2-3 weeks just because of the lesioning effect of the electrode and whatever electrodes we have put in during surgery. And then once the battery is turned on, they get good effect, back up again, and that's a continuous effect.
Thank you, Dr. Vishwanathan. Nitya, question for you about what the name of the movie was that you showed.
Yeah, the name of the movie is called Talk Talk.
It's a Spanish movie and it's available on Netflix. I mean, it's quite
Oh,
an
acha.
interesting movie.
You know, I thought you were showing a TikTok video.
Oh no, it's called Talk Talk.
Okay.
So it's
all
quite
right,
an
it's
interesting
Talk.
movie. It shows
Okay.
about group therapy and how various individuals with various OCD come together and they try to work out their issues. It's a beautiful movie. It's worth seeing.
Okay. In fact, there was another question for you in the Q&A. I'm trying to get to that particular question.
Sure.
It's about therapy typing. Can we use REBT from Revati Chandran?
Yep, sure. I mean, REBT is another therapeutic measure which can be used. So after the behavior therapy came the REBT.
Can you enlighten us? We are poor non-psychologists.
Sorry. Rational emotive therapy. Rational emotive behavior therapy. So what they're trying to do is like you're trying to rationalize. So after the behavior therapy, before the CBT, the REBT came in the picture. So what happens in the REBT is primarily we look at, again, the belief system. So with OCD, since they have issues with the belief system as well, so we try to challenge the belief, dispute it, and help them to restructure and come up with a positive belief system. So REBT definitely would be one of the therapy which we could think about using as well.
Thank you. Mr. Rambatla had a question which Dr. Dr. Archana has answered. In case of autism patients, would you treat the OCD or would the holistic treatment of autism take care of the OCD tendencies? I wanted to just extend that question. In an adolescent or adult with autism who also has comorbid OCD, and of course, first of all, it's very difficult to diagnose, isn't it? Because some of the repetitive behaviors can seem very obsessional. Could you enlighten us both about how you distinguish and between autistic symptoms and obsessive compulsive symptoms in that group? Because this is a common problem in adults with mental disability, not necessarily people with autism alone. And are there, in terms of drug therapy, is there anything else you would suggest for this group?
Actually, autism, OCD and autism, they have a good share among themselves, wherein the autistic patients, a small percentage of them do show OCD symptoms. But as already told, the repetitive behavior, it becomes difficult for us to differentiate whether it is a compulsion. So the first thing is, if it is an adolescent still, we will be able to get some amount of history from the parent or the people who work with them, especially the psychologists and the team members, wherein the repetitive behavior would be in response to a particular stimulus. Wherein OCD, if it is a compulsion, it would be continuous and probably we can establish a pattern for the compulsion. But still, it is very difficult to differentiate between the two. And if we feel that the repetitive behavior is more edging towards compulsion, then probably we will have to treat OCD as a comorbid condition along with autism and start the patient on an SSRI or a TCA, or if he or she is already on something, increase the dose of that particular drug.
Okay. Thank you. There's another question from Krishnantini Shivashankar. Is OCD age specific? Would you like to just comment on that, Dr. Archana?
I wouldn't say it is age specific, but usually studies have shown that late adolescence and early adulthood is the time when the symptoms start developing. But many of us might not pick it up at that time. So the time of seeking treatment might actually be quite late. But then when we probe into the history and we ask certain questions, then the patients would come up with answers like, yeah, I had this even when I was in college. I had this when I was in school, but probably it was just a starting stage and not very severe, and it was like sort of overlooked at. But studies have shown that usually symptoms start at this age, but it is nothing like age specific. They can come to us even in their mid-30s, but a proper tracking of history can show us when it actually started.
Thank you. There's a question from Dr. Nandakumar Rao. I hear that there is some herbal treatment for depression. Any details? Dr. Rama, I was also going to ask you for if someone had OCD, is there, you mentioned quite a few things, but what should we have in our home remedy kit?
Okay. I think ashwagandha is a herb that there are there's not studies about. I mean, there aren't any conclusive studies, but it is being used for its antidepressant and for its relaxing properties. So anxiety and antidepressant. In terms of herbs, I think that's there, and the others that I spoke about in the home remedy is the turmeric and the poppy seeds, and yeah, I think those are the two I did speak about. The rest all contribute to general health as a whole. So yeah, and the external treatments, we of course use oils in the Ayurveda treatments. So the external treatments we do. Yeah. You're muted.
Oops. Vivek, is there anyone whose hand has gone up that you would like to invite?
No, sir, there is no hands up so far. There is one, Miss Vidya Venkatesan. So I will unmute.
Yeah.
Please ask your question. Miss Vidya Venkatesan, you can unmute yourself and you can ask your question.
Hear me now?
Yeah.
Yes.
Yeah, this the cycle. Thank you, Dr. Archana. Your slides were very clear about OCD. The cycle that you explained about OCD is what I experience with Kishan almost every day. So these anxieties, repetitive thoughts, these obsessive thoughts triggers an anxiety, and anxiety triggers a compulsive behavior. Then he gets a relief after that behavior. So how can it be helped to make it better? Because we are almost experiencing it every day, and that triggers him mostly. Hello?
Yeah, Dr. Archana, would you like to unmute yourself?
I didn't understand the last part which she said. Something triggers his OCD. I didn't hear it.
The repetitive thoughts triggers obsessive thoughts.
Okay.
Triggers his anxiety. Anxiety triggers his compulsive behavior, and behavior is mostly kind of an aggressive, or he wants to be violent, and he gets a relief after getting to be aggressive.
Yeah,
So,
the way in which we work is apart from the pharmacotherapy, we get to know the content of the obsession which the patient is experiencing, and the reason for the compulsion. So we try to see how he expresses it in his day-to-day life and try to break it down into small pieces for him to see that how he can replace the compulsion with something which is doable. So that is what is being explained in CBT. It will take time. It will take at least a minimum of 10 sessions to work out on the entire process. But it is doable, and if it's a child, the mother can be equally involved in helping the child to overcome it. So yeah, so CBT will definitely help the kid.
we have been going through this treatment for a long time, but until today, we are still having a great difficulty in managing his obsessive thoughts, and his because triggered by anxiety, and then he becomes very aggressive after that. I don't know how to explain it, but the cycle that you explained was very clear to me, that this is what happens with him. So they're also
Mrs.
kind
Vidya,
of
maybe Mrs. Vidya, maybe we should arrange for you to sit down and have a chat with Dr. Archana and
Okay, sure.
go through the cycle and break it
I
down.
have another question, doctor. You always mention about sameness for Kishan. The sameness is affecting him so much and his life cycle, and it's affecting me also every day, even especially in food and all this. Is the sameness is related to characteristics of autism, or because of OCD?
So need for sameness is a very autistic characteristic. It is one of the first things that was described about autism independently by two experts, one from Europe and one from America in the 1930s. at a time when they didn't know what the other was doing. So it was two independent experts talking about the need for sameness. And I think that's a very autistic trait. Having said that, someone without autism but with OCD has a preference of sameness, has a preference for certain predictable, activities and rituals. I think, since we know each other well and we've known Kishan well, I think there's no doubt that his primary need for sameness is developmental. That means it comes from the autism side. Uh, the the other things we need to look at a little more to understand if there's a comorbid OCD. And so it's a good point that you brought up. So we will, we learn. Yeah.
Another thing
Ahead,
I want to
please.
ask you is, it was the insight into the DBS which Dr. Vishwanath said. My family has been discussing about it and saying that there is some doctor who does a surgery and all this in Delhi. So we didn't. It's not that we didn't think about it for Kishan, because the only problem for him is his thoughts, which makes him aggressive. So can it? Is there any way we can think about it for him in future? Because by all means, we want him to get out of this as soon as possible, since he's nearing his teenage and almost into the teenage and nearing his adult. We are a bit worried about this kind of a behavior every time.
Thank you for that question. I think it's a very interesting one, Dr. Vishwanath. Just to summarize, we are talking about adolescent with features of autism and with emotional discontrol that comes from repetitive thoughts. And obviously, he is definitely intractable in the sense that drug treatment has been challenging. Non-drug therapies have had limited effect. Some effect, but I wouldn't, say 50% effect. So the family is concerned about psychosurgery, and when at all a person can be considered for psychosurgery, even if they're intractable young. At what age would you consider them?
The trials that have all been done, the age has been between 15 to 65 years. Not to say that it cannot be done younger or older than that, but it's just that they choose for doing any of these trials, they choose this age group. The patients that I have operated for pure OCD is about 44, but he was, as Dr. Archana mentioned, he was pretty severely wrecked for 20, 30 years before that. He has lost his business, lost his family, lost, everything. Stuck, his whatever compulsion is, he goes into the bathroom and cannot come out, that kind of thing. For this young man, maybe, the experts are both yourself and Dr. Archana to piece together how much is the OCD part, how much is the autism part. DBS has also been tried for autism, but again, that is even more at a primitive stage than that. There, the electrode has been placed in the medial temporal lobe in the amygdala. In the same location as, if anger, aggression, those things are there, maybe we could consider placing the electrode in the amygdala region. If OCD is a problem, then the area that I usually stimulate is what is called the anterior limb of the internal capsule, where the deepest electrode goes into the basal sort of nuclear area. So all of these are finally a part of the Pepper circuit anyway. So the question as to, yes, if he is intractable, then he ticks one box. The second question is, would he be able to consent, would be the second box that needs to be ticked. And then it is, if both the patient and the family are in agreement, then we need to take it through the sort of channels. To the best of my knowledge, there is nobody doing it in Delhi. There is a surgeon who has done DBS for psychiatric indications in Mumbai. And then to the best of my knowledge, I am the only other. NIMHANS is planning quite actively to start it, but they have not yet started.
Thank you. I think obviously the parent would be greatly helped by talking to both Dr. Archana and yourself. So we'll make those arrangements to have consultations.
Thank you. Would love to help them.
Since we are in the COVID time, I'll finish with a COVID question. We have more than one person asking, and I'll put this to Nitya. Is there a kind of explosion of OCD in the time of COVID. In other words, not just people with OCD having symptoms getting worse, but people who previously were not thought to be obsessive compulsive. You've been working on the front line, so you should tell us. Nitya, that's for you.
Yes, right. Okay, so with one thing, couple of things, two things which we surprisingly notice is one, people with OCD, things did worsen for one group of people. The other set of people actually felt much better, because now they said that, you know what, do you realize what we go through? So the distress was a little different, though they did have the compulsions of cleaning, but the emotional distress was a little, and it was a bit surprising for us as well when people, I mean, we were doing tele-psychiatric work, so we do have people calling in because initially they couldn't come to the hospital because of the lockdown. So one group, yes, they're very distressed, they want more help, and the other group, they were actually sharing that they felt much better. And they said that, you know, people can now empathize with us. So the distress was a little different. So yes, that's what I would like to add on my end.
I suppose if anyone is in doubt, they need to talk to a mental health professional and get their minds clarified about the symptoms.
Definitely.
Yeah. Thank you. So it comes, you know, first I'd like to thank the very interested audience that's stayed with us right through an almost 2-hour session. Thank you so much for being here, and thank you for joining this webinar. I really hope you found it useful. I'd like to thank all our speakers for taking the time to prepare, for keeping to time, and being sharp in their presentations. As you can see, we have a bunch of really smart cookies in Buddhi Clinic. And therefore, you know, you should reach out to us further if you'd like to talk about any symptoms or talk about collaborating with us or working further in the general area of the brain and mind. Stay safe during COVID, and good night. Thank you very much, everyone.